Hello everyone, this is Dr. Kavya here. I'm sorry for the delay in posting this video because I have been busy with my new job and adjusting to the job environment and all. And okay, without any delay, let's get into this video. Similar to the previous videos in this series, today let's discuss the important clinical presentations and how to diagnose them and very few important points about them which you must know. 34. There is a case that is the newborn is presenting with late separation of umbilical cord that is more than 30 days with no pus and recurrent skin and mucosal bacterial infection. Whenever you see there is a delayed separation of umbilical cord, is that the first and foremost differential diagnosis might be leukocyte adhesion deficiency, that is type 1. It is caused due to defect in the LFA1 integrin. It is also called as CD18 protein on phagocytes. Because of this defective protein, there is impaired migration and chemotaxis of the leukocytes. It is an autosomal recessive condition. The clinical findings we can see in this case are late separation of umbilical cord and absent pus and dysfunctional neutrophils, which leads to recurrent skin and mucosal bacterial infections. The findings which we can see in laboratory tests are there is increased count of neutrophils in the blood but absence of neutrophils at the infection site. Even though the neutrophils are more in the blood, they do not reach the infection site, so there will be no pus formation and there will be impaired wound healing. 35. There is a case of recurrent infections and granulomas with catalase positive organisms. The points in the case that suggest our diagnosis as chronic granulomatous disease are granulomas with catalase positive organisms. The defect here lies in the NADPH oxidase. Because of the defective NADPH oxidase, there is decreased formation of reactive oxygen species such as superoxide dismutase, and which leads to decreased respiratory burst in the neutrophils. This respiratory burst in the neutrophils is responsible for phagocytosis and for immunity. As there is a decreased respiratory burst in neutrophils, there will be recurrent infections and granuloma formation. The most common type of chronic granulomatous disease is X-linked form. And the laboratory findings to confirm this NADPH defect, we can do two tests, and the first one is dihydrorhodomin test. It is a flow cytometry. The dihydrorhodomin 123 dye, which is non-fluorescent, on reduction it is converted to rhodomin 123, which is green fluorescence, which gives green fluorescence. In this chronic granulomatous diseases, because of the NADPH defect, this green fluorescence will not be seen as much of that with a normal person. And the second test is nitroblue tetrazolium dye reduction test. This NBT test is a semi-quantitative assay. It is used to test the phagocytic function of polymorphonuclear leukocytes. These cells, they reduce the colorless NBT into the blue-black deposit within the cell, whereas in chronic granulomatous diseases, the polymorphonuclear leukocytes will not turn into blue. As you can see in this picture, the left side one is a patient with chronic granulomatous diseases not showing the blue color with NBT test, and the right side one is a normal NBT test. 36. There is a case of anaphylaxis followed by blood transfusion. There are many causes for post-blood transfusion reactions, and the most of them are related to immunological or febrile reactions. Febrile reactions are the most common, and one of the cause which leads to anaphylaxis after blood transfusion is IgA deficiency, that is selective IgA deficiency. The cause for IgA deficiency is mostly unknown. It is the most common primary immunodeficiency. There are 5 symptoms which you can remember with 5 A's. They are most commonly the condition is asymptomatic. There will be no fever, and sometimes there may be airway and GI infections. It is an autoimmune disease. It is characterized by atopy, and finally anaphylaxis to IgA in the blood products. The lab findings which we can see in selective IgA deficiency are decreased IgA with normal IgG and IgM levels, and these patients have increased susceptibility to giardiasis. The other most important feature of this IgA deficiency is it can cause false negative celiac disease test. 37. There is a case with recurrent cold abscesses which are non-inflamed. The point to be noted here: eczema, high serum IgE and high eosinophils. The diagnosis in this case would be obviously the hyper IgE syndrome, which is also known as Job syndrome. It is a T cell disorder and it is due to the neutrophil chemotaxis impairment or abnormality. Job syndrome is an autosomal dominant condition. It is due to the deficiency of Th17 cells, which occurs due to STAT3 mutation. Because of this STAT3 mutation, there will be impaired recruitment of neutrophils to the sites of infection. The patients with Job syndrome present with cold staphylococcal abscesses which are not inflamed, and they have retained baby teeth, coarse faces, dermatological problems like eczema, and raised IgE in the levels in the blood, and the bone fractures from the minor trauma. You can remember these clinical presentations as learn the ABCDEFs to get a job. 38. The case presents as a male child with recurrent infections and no mature B cells. You have to note this point that there are no mature B cells. The most common diagnosis which we can get is Bruton's disease or X-linked A-gamma globulinemia. This Bruton's disease is due to the defect in BTK gene, which is the tyrosine kinase gene, which leads to no maturation of the B cells. It is most commonly an X-linked recessive condition, so the incidence of this Bruton's disease is higher in males. The clinical presentation starts after the 6 months of age, because up to 6 months the maternal IgG protects the baby from the infections, whereas after the 6 months the level of the maternal IgG decreases in the baby, and the infant is susceptible to recurrent bacterial and enteroviral infections after that. Laboratory findings here are there are absent B cells in peripheral blood smear, and the immunoglobulins of all classes are decreased. The lymph nodes and tonsils are also very scanty or they may be absent. Even in the tonsils, especially the primary follicles and the germinal centers are absent in many cases. So, as a result, the live vaccines are contraindicated in these patients. Number 39. The case presents with a fever, vomiting, diarrhea, desquamating rash, following the use of nasal pack or vaginal tampon. The diagnosis would be staphylococcal toxic shock syndrome. Let us know a few details about Staphylococcus aureus. It is a gram-positive, beta-hemolytic, catalase positive, and coagulase positive cocci which occur in clusters. The protein A is the virulence factor of Staphylococcus aureus. The most common colonizing areas of Staph aureus in the normal human body are nasal nares, ear, axilla, and also groin. The variety of diseases caused by Staphylococcus aureus are categorized into two types, that is the inflammatory disease and the toxin mediated disease. The inflammatory disease may present as skin infections, any organ abscesses, pneumonia. It is most oftenly after influenza virus infection, infective endocarditis, septic arthritis, and osteomyelitis. Whereas the toxin mediated diseases due to Staphylococcus aureus are toxic shock syndrome because of the TSTT1 superantigen, and scalded skin syndrome because of the exfoliative toxin, and the rapid onset food poisoning due to enterotoxins. The TSTT1 is a superantigen. It binds to MHC2 and T cell receptors. So as a result, it causes polyclonal T cell activation and cytokine release. The clinical presentation of toxic shock syndrome are fever, vomiting, diarrhea, rash, desquamation, shock, and organ failure. The toxic shock syndrome, it results in elevated AST and ALT and bilirubin levels also. It is most commonly associated with prolonged use of vaginal tampons or nasal packing. It is differentiated from the toxic shock like syndrome, which is caused due to Streptococcus pyogenes, because in Streptococcus pyogenes toxic shock like syndrome there will be painful skin infections, whereas in Staphylococcus aureus there will be rash and desquamation with fever. Number 40. There is a case presentation with strawberry tongue. Actually, it is not a case presentation. It is just a differential diagnosis we should think of when we see a strawberry tongue. The first one is scarlet fever, and the second one is the Kawasaki disease. Kawasaki disease is an autoimmune condition, and we'll discuss about it later. But at present, let's discuss about scarlet fever and what are the clinical presentations and findings. The scarlet fever is caused by Streptococcus pyogenes, which comes under group A Streptococci. They are gram-positive cocci which are arranged in chains. The variety of diseases which are caused due to Streptococcus pyogenes are categorized mainly under three types, that is pyogenic, toxigenic, and immunologic. The pyogenic infections are pharyngitis, cellulitis, impetigo. That is, in impetigo there will be honey crusted lesions over the face, especially around the nose and mouth. It is most commonly seen in children and erysipelas. And the toxigenic conditions which are caused by Streptococcus pyogenes are scarlet fever, toxic shock-like syndrome, and necrotizing fasciitis. And the immunological conditions are rheumatic fever and glomerulonephritis. Key virulence factors of Streptococcus pyogenes are DNase, erythrogenic exotoxin, streptokinase, and streptolysin O. The diagnosis is mainly by ASO titers or anti-DNase B antibodies. The presence of these anti-DNase B antibodies indicate recent Streptococcus pyogenes infection. The clinical features of scarlet fever per se are blanching and sandpaper-like body rash, along with strawberry tongue and circumoral pallor in the setting of group A streptococcal pharyngitis, which is caused due to erythrogenic toxin. 41. There is a case of flaccid paralysis in a newborn after ingestion of the honey. And the diagnosis here would be Clostridium botulinum infection. It is also called as floppy baby syndrome. The Clostridia are gram-positive spore-forming and obligate anaerobic rods. The Clostridium botulinum produces a heat-labile toxins which inhibits the acetylcholine release at the neuromuscular junction by acting, or it cleaves the snare proteins which are involved in neurotransmission and causing botulism. In babies, the ingestion of spores, that is which are present in the honey, leads to the disease called as floppy baby syndrome, whereas in adults the disease is caused by ingestion of preformed toxin which may be present most commonly in the canned food. The clinical features of botulinum can be remembered by 5 Ds. First is diplopia, and next dysarthria, dysphagia, dyspnea, and descending flaccid paralysis. Or the treatment is human botulinum immunoglobulin. The other special uses of this botulinum toxin are: it is given as local Botox injections in treating facial dystonias, hyperhidrosis, or muscle spasms. And recently, there is an exponential growth in use of this Botox injections for cosmetic purposes in case of to reduce the facial wrinkles. Number 42. The case presents with abdominal pain, diarrhea, leukocytosis, and recent antibiotic use. There is broad spectrum antibiotic use. Whenever there is a diarrheal episode after the recent broad spectrum antibiotic usage, it is most commonly due to Clostridium difficile. This organism produces toxin A and toxin B, which act on the enterocytes and further leads to the condition of watery diarrhea. This condition is called as pseudomembrane colitis. It is secondary to the antibiotic overusage. The clinical presentations in the fulminant infection may be toxic megacolon ileus. It may also lead to shock eventually. The diagnosis is done by PCR or antigen detection of one or both the toxins in the stool of the patient, and the treatment includes oral vancomycin or fidaxomicin. And if in resistant cases, the fecal microbiota transplant can also be done and tried. It has given best results in the resistant cases. That's it, friends. These are the few clinical presentations for today, and I'll be posting the next video as soon as possible. If you don't want to miss the series, kindly subscribe to my channel and press the bell icon so that you'll be notified.